Good afternoon, everyone, and welcome to today's event hosted by Region 8, Chapter of HFMA. Today's webinar is titled Provide-Based Billing. It really is rocket science. I would like to welcome today's guest presenter, Linda Corley. Linda is the VP of Compliance for XTend Healthcare. Linda has worked collaboratively with hospitals and physician offices for the past 25 years. Linda served as controller of a university-owned four-hospital group while providing insight to clinical and financial staff members on compliant reimbursement. Linda is a coder and a frequent HFMA presenter with over 15 years of experience leading CDM reviews, coding and billing audits, and providing consulting services for revenue cycle improvement. Without further delay, I will turn it over to our presenter. Linda, please go ahead.
Thank you, and good afternoon, everyone. I'm delighted to be here with you to talk about provider-based billing. Thank you for joining us. So as we begin today, I will let you know that this is a very information-packed presentation. Some of the slides I will just touch on briefly because I believe a lot of this information is basic, and you will probably already know that. But then I'll go into some of the new developments regarding particularly off-campus provider-based clinics. So as we begin this afternoon, I always like to start with information regarding the acronyms that may be included within this presentation. Most of these I remember, but sometimes when I'm viewing information, I simply want to have a legend or some definitions that I can go back to that let you know what all the acronyms stand for. For today's presentation, I wanted to mention briefly why provider-based status is so popular and why we are seeing more and more requests for provider-based departments or clinics of hospitals. Talk about new audit and OIG emphasis on provider-based services. Talk about some identified operating and then billing errors that we certainly want to discuss how to correct those. And truly just look at what does provider-based mean, because I think there are lots of definitions out there, and as is often the case with healthcare, we have several different terms that refer to similar services within our healthcare environment. There are some CMS provider-based definitions that I want to be sure that you have. Talk about the guidance of how to become a provider-based service area, and then what obligations come with that provider-based status. Certainly some good reimbursement in some cases, and then understanding what your obligations may be. Back in 2012, we did have the new requirement of including 3-day payment window services within when we roll our services for that 3-day window into our inpatient claim. We certainly now have new requirements for including some of those outpatient provider-based services, both professional and facility or technical services. Provider-based payment review, I think the biggest question for us all is, does it always mean increased cash when we are able to change to that provider-based status? And then, of course, compliance is extremely important to all of us. Not only do we want to qualify for perhaps increased cash, but we want to be sure that we are compliant with our processes to earn that cash so that we can keep it once we do receive it. So why so many questions about provider-based services? I do think because of the number of independent physicians and, of course, entire practices that are becoming hospital employed, certainly that has brought provider-based more to the forefront of how services are being provided. Many hospitals do prefer to qualify for provider-based status, because reimbursement is often, but not always, higher than freestanding physician. Certainly hospital outpatient services through APCs, which are ambulatory payment classifications, are paid at a higher rate than the usual Medicare physician fee schedule. The hospital is able to include their provider-based cost on the Medicare cost report, so that is also a benefit of provider-based status. However, looking back over the past 5 to 7 years, we do know that CMS has been concerned regarding a significant number of our hospitals who are falling short of what is mandated for provider-based status, and we're going to discuss some of those mandates. The OIG for the past 4 years has listed provider-based noncompliance as one of its top concerns, and I have worked with several hospitals just over the past 2 years who have had their provider-based status reviewed, and the OIG does continue to audit the services that are being billed as provider-based to make sure all of the mandates for providing the services, how they are charged and billed to patients, and the reimbursement received. Those audits are ongoing to ensure compliance. And if we look at both the current administration and certainly the past administration for CMS, has been actively expanding their use of payment recapture audits in all of our federal reimbursement programs. Provider-based, if I just had to give an opinion, I would put at the very top of those audits as far as being paid appropriately. The Joint Commission back several years ago did survey a Midwest hospital operating as a provider-based clinic. During that evaluation, the accrediting organization determined there was a lack of medical record integration between the hospital and the clinic. As a result, the Commission did cite the hospital for deficiencies, and of course that's part of what today's presentation is all about. Not only do we want to be able to bill provider-based services appropriately, but we want to ensure all of those individual requirements for provider-based are being consistently followed. And that consistent word is extremely important. I think generally when we are reviewing or when we are focusing on a particular area of operations and billing, certainly we take the time to review and ensure that appropriate procedures are in place. However, I think you will agree provider-based takes a little more attention, perhaps auditing on a monthly basis, to ensure the information or data being billed on our claims is appropriate for where the services were provided and how those services were carried out. The biggest error that we have seen in the past, according to CMS, is place of service coding errors. Now they call them coding, which I know it is a code for place of service, but a lot of times I see these place of service errors coming from the billing office. In the past, these were undetected because we had a different fiscal intermediary processing our Part A hospital claims from that Part B agent, I think we generally called them, or carrier. We had two different groups processing our claims for payment, so the errors were not as evident. However, now, as all of you know, we have changed to a single Medicare administrative contractor that processes and pays both facility or technical component claims as well as professional claims. So they are certainly easy to bump up against each other and see what discrepancies are there. If the hospital operates a physician clinic as a provider-based clinic, Medicare determines that it does not meet provider-based criteria, of course there will be fines and recoupments of any inappropriate payments that have been made. Regulation 42 CFR defines what operations are identified as a Medicare certified provider for provider-based versus a supplier such as DME, durable medical equipment. This particular regulation does determine what hospital services can be billed under the Medicare provider number as provider-based. So when we look at an individual provider, we know that CMS or Medicare identifies separate hospitals, critical access hospitals, skilled nursing facilities, home health, hospice, CORFs, FQHCs, and then CMHCs. So all of these different types of providers are identified by Medicare. And as you know, just to confuse ourselves, sometimes we refer to physicians and or even other clinicians and therapists as providers. However, in this case for provider-based service, CMS does define the provider as the hospital. A provider-based location or site means it is simply part of the hospital and our services are being billed as hospital outpatient services. We want to be careful, of course, with the word clinic because we have various interpretations. I think we use clinic because of some of the clinics that we have traditionally referred to, like a wound care clinic or some of the others that we name. However, keep in mind that we're going to utilize provider-based to refer to the type of services being provided that are part of the hospital outpatient service group. The particular regulation that does define provider-based status is not applicable to these, and that's why we do not talk about provider-based services for these listed different types of providers, and I won't read those to you. You can see those there. However, based on these exclusions, the provider-based statute effectively only applies to hospital outpatient departments and rural health clinics. Remember, a provider-based entity does have a separate, different provider number. However, a provider-based location, such as we are referring to, hospital outpatient or hospital clinic, has the same provider number as the hospital itself. And I think that's an important differentiator to keep in mind. These are just definitions that I pulled from that CMS regulation so that you would have them as part of your resource. The main provider, of course, for provider-based services is the hospital that creates or acquires another location to deliver additional services in its name. Campus refers to that physical area of main buildings of the hospital or within 250 yards. A department of a provider could be a facility an organization that is owned or acquired by the main provider to offer medical services or clinical services in its name. Certainly a provider-based location must be identified through signage and communication efforts in the very same way as part of the main provider. So our marketing materials, registration forms, and other registration materials, how the phone is listed, websites, all have to refer to the hospital itself. Looking at a provider-based entity may be a separately certified provider owned by the main provider, and this is the traditional hospital-based concept. So if I look at a skilled nursing facility, that's going to be a provider-based entity on its own, separate from the hospital itself. We do have some remote locations of hospitals, which would simply be another site that furnishes inpatient hospital services. And then if we move away from all of those and look at a freestanding facility, that is an entity that is not provider-based, not owned by a hospital, and also not run, or the services are not carried out as hospital services. Campus gets a lot of discussion these days, as you will see. The reason why we are concerned about on-campus locations versus off-campus. The physical area immediately adjacent to the hospital or the provider's main buildings, and all of the other areas and structures that are not strictly contiguous to the main buildings but are located within 250 yards. All of this is important for defining how provider-based services not only are going to be billed, but also how they are going to be reimbursed, as we will discuss. A department of a provider, of course, we talk often about radiology, laboratory, and of course now we can recognize that provider-based area of services as a department, and as I mentioned before, the license for a provider-based department is the same as that for the hospital. The department is not licensed to provide healthcare services in its own right and is not by itself qualified to participate in Medicare as a provider. It is part of that main provider, the hospital, with which it is connected. Medicare conditions of participation do not apply to a department as an independent entity. And that is important at times because a problem with a particular department or provider-based clinic can cause a review by Medicare regarding whether or not the hospital is meeting their conditions of participation. All of that is tied together. Freestanding, as I mentioned, that is an entity or a service area that furnishes healthcare services to Medicare beneficiaries and is not integrated with any other entity as a main provider. It's not a department of a provider. It's not a remote location of a hospital. And it is not a provider-based entity. It is simply a different type of ownership standing on its own to serve Medicare beneficiaries. The main provider, of course, is that hospital that either creates or acquires ownership of another entity to deliver additional health care services under its name, certainly under its ownership, and under its financial and administrative control. So when we get down to the actual definition of a provider-based entity, that is a provider of health care services that is either created by or acquired by a main hospital provider for the purpose of furnishing health care services that are different from those of the main provider under the name, ownership, and administrative and financial control of that main provider, as we have talked about. More definitions, and some of these I'll leave just for you to read. A universal provider-based department must meet these particular CMS requirements. Common licensure for both, if that is allowed by state law. Certainly financial integration is there at the top of the list, and financial integration is one of those areas that CMS and the OIG has been reviewing in the last audits of say, the last 2 to 3 years. Financial must be included in the hospital trial balance. This is the provider-based services that we are talking about. Must be included in the allowable cost centers on the Medicare cost report, same as any other hospital department. And then clinical integration is also high on the list. The provider-based area or department must have the same clinical oversight as any hospital department, and that means they must have the same medical director. Quality assurance must be carried out in the same manner or using the same policies and procedure. Certainly utilization review, all of the clinical review must be carried on the same for the provider-based area or department or clinic as is for the hospital. Medical records, and this one has become more important to us, there must be either a unified retrieval system or a system that is able to be cross-referenced so that charts for the provider-based area are readily available at all locations. The medical staff of the hospital must have clinical privileges at the provider-based site or facility. Off-campus is a little bit different, and we will continue to bring out what is different about off-campus and how off-campus sites have been affected by legislation or by regulatory requirements in both 2016 and 2017. There must be required management contract terms so that the provider's control is clear. Policies and procedures written the same and carried out the same, and that's why I mentioned that word consistency to you again. The provider must employ all non-management staff members who provide patient care excluding those that can separately bill under their own provider number, such as a physician or a mid-level. The management and leadership employees must follow provider policies, those of the hospital. Managers' policies must be approved by the hospital provider. There must be periodic written reports required to the provider from the provider-based area, and then on-site staff members must be subject to the provider or the hospital's approval. So all of these refer to the hospital's off-campus sites for provider-based services. They also must meet that same common ownership, same legal entity and governing body, administration and supervision, the same as any other provider-based department, human resources, all of those service areas that you see there the structure must be the same, and they must be carried out for the same as for hospital employees. And as we know, that off-campus provider site must be located within 35 miles of the main provider or meet a market share test. Certainly, management contract rules will apply, and then joint ventures for provider-based services are not allowed, or they are prohibited. Other requirements, we do know that a provider-based clinic may be on the hospital's main campus or within 35 miles to qualify for off-campus, must operate under the main provider's, the hospital's license, as we mentioned, unless the state requires a different licensure. The provider-based clinic must have ready access to the hospital's and other provider-based clinics' medical records, very important. And then physicians and staff operating within the provider-based clinic or area are under the same reporting structure as all other hospital departments. The provider-based clinic or outpatient department must be incorporated into the hospital's organizational chart. And I wanted to include all of these just as a review and as a resource, so you will see all of the operational requirements that continue on for both on-campus and off-campus provider-based clinics, even though we're going to talk about different payment methodologies for off-campus. More requirements: the directors and the managers for that provider-based area must be involved in the same meetings as their peers in other hospital departments. We mentioned hospital privileges must be granted to the professional staff for the provider-based department or area. The support staff must receive the same in-service training as the clinical support staff of the hospital. Hospital policies on infection control, safety, disaster plans, all of those hospital or main provider operating policies and procedures must be not only part of the provider-based operating system, but must be consistently addressed. We mentioned signage, certainly an important audit area for that provider-based clinic, as we are finding out from the audits. We mentioned the provider-based clinic or area must be on the hospital's trial balance as a separately identifiable cost center, must use the same charge description as the hospital. In other words, the charge structure for services must be the same for hospital outpatient services as it will be in that provider-based service area. Medicare patients must be registered as hospital patients, and I can't say that enough. If you are operating a hospital-based service area, department, or clinic, your Medicare patients must be registered as hospital outpatients. So what has changed? Place of service, I mentioned that to you, primarily because in the past, CMS and the OIG have identified errors on how professional service claims are being filled out, or submitted, I should say. And as you know, we're billing those professional services on a CMS 1500 claim form. If you are billing Medicare for those professional service and you are in or you are billing provider-based services, you would not use place of service 11. 11 is only for office-based or freestanding physician services. We either must use for Medicare place of service 22, which is a hospital on-campus outpatient service area, or 19, place of service, which is a hospital off-campus outpatient service area. And as previously mentioned, all terms of the Medicare Provider Agreement, which generally we see in the hospital's conditions of participation, must be carried out. A deficiency at any site will jeopardize the entire hospital provider status. So that's an important one to us, to be sure that we are bringing in all of our hospital-based provider service areas to be part of our provider agreement to meet the conditions of participation. Non-discrimination provisions certainly are applicable to physicians, and then EMTALA becomes an important obligation if our provider-based services are on campus. EMTALA will apply as part of the hospital. If our provider-based services are off campus, EMTALA will only apply if that service area is held out as urgent care, or if greater than 1/3 of our patient visits are unscheduled. So I always like to bring up EMTALA because I have seen a hospital penalized in the past 2 years for not meeting their EMTALA obligations in an on-campus provider-based service area. To go back to those off-campus departments, for 2016, CMS or Medicare did implement new coding and billing guidance for new modifiers for provider-based claims other than rural health clinics. And of course, I've already mentioned to you the new place of service code for those 1,500 or professional claims. PO modifier should be appended to every HCPCS code on the facility claim. This new place of service code 19 also will be shown on those professional claims for outpatient hospital provider-based services. We will continue to use place of service code 22 for on-campus outpatient services. For 2017, we did have the new ruling or regulatory information that only accepted off-campus provider-based departments or clinics will continue to be paid under outpatient prospective payment. Now, what does accepted mean? Those provider-based areas that were operating and billing as off-campus provider-based departments before November 2nd, 2015 are accepted and will still be paid under OPPS. You can include as accepted those that were under development but not yet billing, and those who had submitted a voluntary provider-based attestation before December 2nd of 2015. Those were grandfathered in. There were also some mid-billed attestations for provider-based areas under construction during the first quarter of 2017. But the important information on this particular slide to me is you either have an accepted off-campus provider-based location if it was operating and billing before November 2nd, 2015, or you have met the under development but not yet billing, or you had already submitted your voluntary provider-based attestation before December 2nd of 2015. Provider-based off-campus locations, as we will see, started last year being paid differently, and that has continued for provider-based off-campus locations for 2018. To look again at what obligations are there, You must treat all Medicare patients as hospital patients with the facility or technical component of the services billed on a UB04. Inpatients of the hospital, as I mentioned to you, the 3-day payment window does apply for that facility component for services in provider-based entities, and we added to that and all diagnostic and related therapeutic professional components. So let me say that one to you again. If you are charging and billing Medicare for a provider-based clinic or a hospital outpatient department, not only must you include your facility components of services provided within the 3-day, we used to call it 72-hour window, but now you must also include on your inpatient claim any diagnostic and related therapeutic professional components that were charged and billed during that 3-day window. Off-campus sites must provide notice of dual coinsurance, and that would be for the facility technical component and for the professional component to each Medicare patient before services are provided unless it is an emergent service. So off-campus sites must provide notice to that Medicare beneficiary of dual coinsurance being charged and collected to each Medicare patient before the services are provided. So to restate the obvious that I've spent a lot of time saying, we're going to use the very same CPT-4 or HCPCS Level 2 codes to bill our physician services provided in an independent freestanding clinic or in a provider-based clinic. We don't have separate codes for the services, so both the physician, professional services, and the provider-based clinic, technical, or sometimes we call those the facility services, are going to be billed using the same CPT and HCPCS Level 2 codes because these are outpatient services. As we know, CMS does pay a greater dollar amount in an independent physician office, but they pay less for the physician component in a provider-based clinic. And I'm sure many of you have looked at that professional fee, what we call the Medicare Physician Fee Schedule, and that particular list of services shows a particular dollar amount to reimburse the physician for his or her services if provided in their own independent, what we call freestanding office, and that is a larger or greater amount than when we look at what the physician will be paid in a hospital outpatient area of service, such as the provider-based clinic. However, when we change to our provider-based clinic or outpatient department services, now Medicare is also paying a separate dollar amount for the related APC, ambulatory payment classification, which is the facility or the technical component that we will bill on a UB04, what we call a hospital or facility claim. CMS has been and continues to be understandably concerned that it does not pay for an individual APC on the hospital UB04 claim and then also pay the non-facility or higher rate for the professional CPT-4 code on that CMS 1500 claim. And I think, again, this is very obvious, but it's difficult to remember when these claims are either being established in your billing system to appropriately charge and bill for the services, and then, of course, we want to be sure that place of service is correctly identified on your 1500 claim so that the physician component or professional component is appropriately paid the lesser amount. We have found, or just my years of working with particular hospitals and physician practices, billers are generally either knowledgeable about Part B, physician payment and claims, in other words, they're used to billing services on a 1500, or they are hospital billers, billing on a UB04 for Part A services. However, a lot of times they do not know both, and that's where I think education and certainly spot audits so that you can reassure yourself these claims are going out the door correctly so that you're being paid compliantly or appropriately for provider-based service. Part B billers generally are accustomed to identifying the correct service provision on a claim by using modifiers. And if you will just keep in mind, on that Part B claim, the professional 1500 claim, generally we are going to identify a technical component, or we're going to use modifier 26 for a professional component. Extremely important. But split billing, a physician office visit for a provider-based clinic, is not really similar to billing a procedure or a diagnostic service with one of those modifiers, either TC or 26. We have no modifiers equivalent to that 26 professional and TC technical that would allow the provider to indicate to Medicare whether it is billing globally or whether it is split billing the professional component and the technical component. So we are submitting both, a split bill, both a 1500 for the professional service and a UB04 for the technical or facility component. So when we change to our provider-based status for outpatient departments and clinics, our billers must be knowledgeable about place of service 22, on campus, place of service 19, off campus for that 1500 claim form. We generally recommend, if you are a physician changing to provider-based status, we would want to not only educate our billing staff, but all departmental staff members about how this is a different payment methodology. Particularly our professional services are being paid based on different requirements and different types of services, so that there's good understanding throughout charge capture, billing, reimbursement, even appealing denials turns out to be just a little bit different for provider-based services. So we want lots of training in detail information regarding place of service. The only way Medicare can make certain the particular CPT code is being paid appropriately is based on that place of service. And I apologize for nagging about that, but I do still see lots of errors when we are working with clients, and based on the audits that I've looked at in the past couple of years, hospitals still have difficulty getting place of service correct, and we know that we never, ever want to bill Medicare for a provider-based outpatient service area using place of service 11 on that professional or 1500 claim. I get a lot of questions about attestations about provider-based status. The application for a provider-based entity or pre-approval by CMS is still not required. That Code of Federal Regulations 42 that I mentioned to you now says may submit the attestation. That's to notify CMS of any provider-based locations. The hospital does state that applicable requirements have been met, and the hospital at that point attests to meeting the obligations for provider-based operations. Also, we may use that attestation to notify CMS of any material changes regarding how hospital outpatient services are being provided. The attestation of provider-based status and meeting the requirements is voluntary, and Medicare continues, or CMS continues, to give us that information. Per Medicare or CMS, provider-based operations depend on the hospital's self-monitoring process, and then of course I had to add until that provider-based area, outpatient department, or clinic is audited. Extremely important that we understand what the requirements are and that they are being consistently followed. There is no official attestation form that has been published. There is a sample format in Medicare or CMS Transmittal 03030 that was issued back on April 18th of 2003. You are instructed, or we are instructed, to send that attestation form to the Medicare administrative contractor that is processing your claims, and then you would also send a copy to the CMS regional office. For on-campus, supporting documentation is not required, but is recommended, and then if you are opening an off-campus location, supporting documentation is required. The Medicare Administrative Contractor, or the MAC, may make a determination of whether it's approved or whether it's accepted is probably the word that they would use. The regional office should either approve or disapprove. Now, we generally recommend that attestations be completed, that the sample format be used, because I think this draws your attention to whether or not you are meeting the requirements for a provider-based location. What are the benefits of submitting the attestation? If you have submitted that attestation and it has been accepted or approved by the regional office, then CMS would only recoup any excess payment if later that provider-based area is found non-compliant. In other words, what that is saying to us is that there would not be any fines. We may have to pay back the money that we were paid inappropriately or non-compliantly, but we would not be assessed a fine. Certainly, as I mentioned, it does trigger a good self-review of the criteria that must be met. The attestation does provide written support that not only have you reviewed what's required for a compliant process, but that you are attesting to that process being followed and that you are attaining that compliant process. It does educate the staff when they are involved in preparing the attestation. It educates all that are involved with what is required. And then we do know that that particular regulation does say that we must evaluate the requirements and determine the legality of provider-based. So having that attestation carried out, submitting it does attest to the fact that we have gone through that review. Certainly Medicare or CMS continues to remind us that a particular area, outpatient department or clinic, is not provider-based just because the hospital believes that area to be. So I will say again, we recommend filing that attestation to meet compliant foundation for the services that you are charging and billing to Medicare as provider-based. What are the financial reasons for filing that provider-based attestation? If the regional office of CMS does accept, as I mentioned, it will limit recoupment if the facility is later determined out of compliance. Without a reviewed attestation on file, CMS can recoup as far back as the applicable statute of limitations, which is generally about 7 years, is what I've been able to find out. If a subsequent review determines that criteria were not met, the additional money reimbursed due to billing as provider-based, of course, will be recouped. Now, provider-based reimbursement, we all are interested in for our hospital outpatient areas because we generally believe it to be greater than freestanding physician services. The amount of or even any increased revenue is not automatic, however, and here are the things that even CMS tells us to review to be sure that we are going to receive increased revenue based on providing these provider-based services. Look at specialty or type of clinical services to be provided. Particularly look at your payer mix. The greater the Medicare percentage of payers, of course, the higher likelihood that provider-based will be greater reimbursed. The volume of services that are being provided in this particular area or outpatient department, and then whether or not you are in a rural versus urban setting. CMS does recommend case-specific analysis for each area or entity. You would want to compare current physician fee schedule, that Medicare physician fee schedule payments, to hospital-based outpatient prospective payment system, which of course are paid under APCs. Certainly look at the additional cost for the technical component versus the physician professional component only, and then review facility RVUs. So some in-depth analysis is needed before any new decision to move to provider-based. And certainly on-campus provider-based is much more attractive these days than off-campus provider-based because of the recent 2016-2017 regulatory changes. But an in-depth review of your payer mix, particularly the services you are providing, how those are being reimbursed. If you have a freestanding physician clinic, let's say, how are those being reimbursed under the Medicare physician fee schedule, and how will you be reimbursed as a provider-based on-campus outpatient area. Mostly reimbursement does result in increased cash outcome. I'm almost reluctant to even say that to you because there are so many factors that affect what you will be paid from Medicare under your provider-based status versus what you would continue to be paid based on a freestanding physician arrangement. Under outpatient prospective payment, or that OPPS I've mentioned to you, the ambulatory payment classifications usually pay more than the fee schedule. However, you do need that comparison of procedure-based specialists. We want to be sure that that comparison does reveal provider-based payment to be greater than the Medicare physician fee schedule. However, we say that they usually pay more, the APCs generally pay more, because it reflects historical reliance on Medicare or CMS building into APCs 24/7, 365-day operations being carried out by the hospital, and that building and equipment investment is generally higher or more costly. Thus, those APCs reimburse more than the Medicare physician fee schedule. Certainly, reimbursement can increase at a greater percentage for critical access hospital provider-based entities. Now, notice that all of this says historically. So again, I would stress to you, if you are considering a new on-campus provider-based outpatient department area or clinic or other services, just be sure you're putting in enough time and energy and effort into a review of the two reimbursement methods. Now, I have prepared the Medicare reimbursement for a Level 3 physician office visit for 2018. Notice this is I think these are Iowa rates, but this is just an example. Please look at your specific services being provided and the reimbursement you are currently receiving versus what you would receive through an APC payment. So in a freestanding physician clinic, now this is just for 99213, the physician would be paid $68.21, by Medicare. In a provider-based clinic, because we are able to bill, as you know, both the professional component, which would pay $48.29, and look at how I mentioned to you that $48.29, because this service by the physician is being provided in a hospital outpatient area, it is less than what the physician would be paid in his or her own clinic. So $48.29 for the professional component, but then Medicare, and Medicare only, keep that in mind, will also reimburse the APC for that 99213, $90.94. Then you would end up with a $139 payment from Medicare for a provider-based on-campus location versus $68.21 in a freestanding physician clinic. A provider-based rural health clinic owned by a hospital with less than 25 beds is exempt from the per-visit reimbursement cap, which is good. The difference depends on the allowable cost of that rural health clinic, and those costs include costs allocated from the hospital. Now, as I mentioned to you, please keep in mind these are national payment rates. Yours may and probably will vary, so this is just an example of a CPT code by CPT code analysis that you should carry out. And I want to add to this particular slide also, we know that for that outpatient prospective payment and APCs, we have new considerations for this year because of Medicare bundling of outpatient services. So even if you have a provider-based on-campus clinic, you probably want to look at your claim examples regarding how they will now be paid by Medicare, because Medicare has included so many comprehensive APCs. I think Medicare has 62 comprehensive APCs for this year, and those comprehensive APCs may affect how your provider-based on-campus service area is being reimbursed. Extremely important. Why would anyone not want to operate a provider-based clinic? Oftentimes I meet with physicians and they will ask me, you know, Linda, this looks like it's too good to be true. Why would you not want to go to an on-campus provider-based service area? And here's just a couple of things that I've been able to come to, or conclusions I've reached. The reason Medicare pays more is because it does cost more to operate a provider-based location that is part of your hospital operations than a freestanding physician clinic. Think about all the requirements. I've taken, 20 or 25 minutes to share with you just what the operational, the clinical service area, all of the additional requirements that you will have to meet the regulations for provider-based that you do not have for a freestanding physician service area. In return for increased reimbursement, Medicare requires increased regulatory compliance, including a decreased acceptance of fraudulent billing, more OIG audits, more MAC audits, and I think we will see even more this year because CMS and the OIG have focused on provider-based status, particularly on campus. If you have an off-campus location, please do some spot audits every month to make sure that your off-campus provider-based facility claims have the appropriate place of service, have the appropriate modifier, and all billing regulations are being carried out. You don't have to do all that many claims, but if you've got off-campus provider-based, just look at 5 on a monthly basis to be sure the billing regulations and the compliance regulations for operating that off-campus provider-based location, those regulations are being followed. I have talked with lots of physicians, particularly those who were in an independent practice prior to working in a provider-based site. Sometimes even at the same location, they have simply either sold or the hospital has acquired their particular practice. Physicians, of course, are not always enthusiastic about all of this additional regulatory oversight, and that Medicare at some point is going to audit the services that are being charged and billed. It can seem, or some hospitals will even say to me, that they have proven to themselves that provider-based services are more trouble and cost more than the increased revenue coming from Medicare. And most of the time I see that when Medicare is a very small percentage of their payer mix. So as I mentioned to you, the greater your percentage of Medicare patients, the more provider-based may result to you in increased reimbursement. I've also noticed this bottom bullet that I think is interesting. The increased reimbursement often leads to increased expectations regarding physician compensation. So I have had doctors say to me, the hospital is being paid more for services now because we are a provider-based clinic, and that physician himself or herself is interested in how they are being paid for the services they are providing. So you want to be sure you've discussed how does Medicare reimbursement in the provider-based location area fit within the organization's existing physician compensation arrangements. So that's just a heads up to look at if you are a hospital considering provider-based services, that you make sure you understand how your physicians are looking to be paid themselves. What's the other, or what I think is the number one drawback with provider-based, is that a significant portion of that increase, particularly in your cash, may be in patient copay or patient responsibility portion of the charge. And again, keep in mind that if you are split billing for provider-based locations, then you are sending 2 claims to Medicare, one on a 1500 claim form for the professional component on which that Medicare beneficiary is going to owe a copay, and then you're also sending a UB04 for the hospital services on which the Medicare beneficiary will owe a copay. So 20% of the hospital facility or technical charge for government payer patients. And actually, when we look for Medicare beneficiaries, if you will look at Addendum B, you will see there the national co-insurance rate. And we are finding for 2018 that that amount is actually greater than 20%, but it is changed every year because CMS or Medicare calculates the payment rate for APCs and then sets the co-insurance amount individually for that particular CPT code. And of course, 20% of the physician fee schedule or the allowable amount for the professional component. So your Medicare beneficiaries who receive services in a provider-based outpatient area will be billed 2 co-insurance amounts. As you see there, consider the possible negative effect of that Medicare patient being responsible for 2 copays or 2 co-insurance amounts. Some Medicare beneficiaries, of course, will have a secondary insurance policy that will pay for that copay or coinsurance, but you just want to be aware of how to handle any negative effect of that Medicare beneficiary being asked to make or to pay 2 copays. We do call this sometimes split billing for Medicare. We're separating the hospital component for the service from the professional component, submitting 2 Medicare claims for the same patient, for the same data service, for the same services as we've discussed. The hospital facility or technical component billed on the UB04, the professional component billed on that CMS 1500, unless a critical access hospital elects to have all-inclusive payment. Bills the same as traditional hospital-based physicians in the emergency department, radiology. That's just to give you an idea of what the 1500 or the professional claim will look like. Private pay, here is a big question on provider-based. Whether you are going to bill or not bill commercial and private payers as provider-based. What Medicare or CMS regulates or tells us that all Medicare patients must be billed as hospital outpatients. However, the CMS regional office has confirmed that this does not apply to Medicare Advantage plans. You know, those are the Medicare HMO policies, and Medicare secondary. So the only payer that you must split bill is Medicare traditional. Private pay point-of-care payment for provider-based services by the patient may be significantly higher. Now, that's what we've said on that previous slide when you look at the how you are going to charge and bill provider-based services. So you want to have scripts so that not only can this be explained to patients, but so that your staff members or your team members can answer the questions that come up. You do have 2 provider-based billing choices. You may split bill all services to all payers using the same 2 charges. And notice that says may. You may split bill all services to all payers, one for the facility component, one for the professional component. You may also adjust off the charge for commercial insurance if that payer does not recognize 510 or that clinic revenue code for the facility component. Now, of course, we see this every day. If I look at a particular private or commercial payer, they are generally used to seeing a professional claim only for that office visit that I mentioned to you, that CPT code 99213. So now, if you are going to send a facility component, UB04 claim, for that 510 revenue code for the facility component, you may know that your particular commercial payer does not recognize that as a reimbursable charge. I have, provider-based clinics that use this particular methodology. However, the CMS guideline says that we only must split bill Medicare, and you may establish a third global charge for your private or commercial payers. Medicare does allow hospitals to bill private and commercial insurers as freestanding, even if the Medicare type of service is provider-based. So I will mention that one again. You can continue to bill your private or commercial payer with whom you have a contract that outlines how you are going to be paid for your services if it does not allow a technical component for that office visit and evaluation, then you can continue to bill commercial and private payers as freestanding. It is Medicare that we must bill as hospital outpatient, and we would have 2 claims going to Medicare. Now again, I have a slide example, and I apologize. I know I'm running over our time, but I will try to be quick. This is strictly for illustration only. Your payment will be different, but some hospitals have shown me this methodology in order to be able to bill the same dollar amount of charge to all patients, but to either bill your freestanding clinic claim on a $1,500 for your private and commercial payers, but then also follow the regulation and bill Medicare appropriately with 2 claims. So if we look at that level 3, 99213, we see in a freestanding clinic, example only, your charge could be $300. We see what Medicare would allow, what Medicare would pay, and what the copay would be. However, for a provider-based clinic, we see splitting that $300 charge into a professional component and a facility component, what Medicare would allow, and then what you would be paid from Medicare. Keep in mind, illustration only, your payment amounts will be different. And again, I will say, keep in mind 2018 APC packaging, because the other services charged and billed on your Medicare claims will have an effect on this reimbursement. Okay. Benefits, certainly being able to bill drugs 340B is important. Some of the others, I won't read those to you because I am over time. You do, as I mentioned to you, if you are considering a new location, you want to be sure that you report it to your MAC within that particular effective date of change. You would use that CMS form 855, which is just the enrollment form. And you see some information there that will help you to be sure that your provider-based attestation is filed appropriately for any new compliance requirements. I get the question, do hospitals have to employ physicians in the provider-based clinic? No, as long as your physician will follow all the rules and billing requirements for Medicare using that using that place of service 22 or 19 if you're in an off-campus. It does work in all other split billing situations. Let's see, and by that I mean that physicians are able to bill in other split billing. If you have a radiologist interpreting the film or the image, then of course he or she is going to bill their own professional service. But you want to be sure, if you are not employing the physicians and you are not in charge of how their claims are being submitted to Medicare, you want to be doing audits so that you know they are compliant. I do say there, if the physician is not employed, it does increase the risk that patients will be treated as private patients of the doctor and not admitted to the hospital outpatient service as is required. So that's one that you want to have control of. Remember EMTALA, we mentioned those requirements particularly for on-campus and then for off-campus, depending on the services being provided. The question I get most often, of course, is provider-based status worth it? It completely depends on your particular payer mix, services being provided, services charged and billed on the claim, and how they are being reimbursed. So as suggested, you do need to perform your due diligence of reviewing this year's Medicare coverage of services, payment methodologies, and billing requirements. I do recommend that you follow any provider-based service location Follow those claims being submitted very closely. Again, you don't have to do huge audits, just do enough audits so that you know what is being billed on the claim has the appropriate coding. I say never take for granted you know what information is being submitted on your Medicare claims, just because I work with hospitals that are so surprised after some Medicare or OIG audits and we find information that is incorrect. You do want to look at your payment receipt closely to make sure you are being paid appropriately if you're billing on-campus provider-based. Remember your cost reporting requirements and then that annual review each January because Medicare outpatient prospective payment changes. So we did make it. Again, I apologize for being late. Christine, do you have questions that I need to answer?
Yeah, we have a couple questions and still a lot of listeners. So if you are able to answer about 3 or 4 questions, yes. I think.
Sure.
Okay, awesome. So our first one is billing commercial payer the same as Medicare?
I think that question almost has to be answered for individual location. You do not have to bill your commercial and private payers the same as you bill Medicare because Medicare requires that split billing or 2 claims. And there are some questions out there regarding how the professional component, what we see a lot of times, I think this question is referring to what we see a lot of times is a patient will be seen in a provider-based clinic and then that patient will be sent to hospital outpatient for a particular, perhaps a more complicated imaging service or sometimes a procedure. So the provider-based clinic claim for a Medicare provider must be billed in the 2 claims. But again, if that patient presents to hospital outpatient, not in the provider-based clinic, those services are going to be billed as they generally are. Remember, Medicare requires service location to be shown on the claim, and where the service is provided is what determines how those services are going to be charged and billed. So the provider-based clinic services would be billed according to the rules we've talked about today. The hospital outpatient service would be charged and billed as we normally would. If my patient goes to the hospital outpatient area for, let's say, an MRI, that MRI is going to be billed on a hospital outpatient claim separate from the provider-based clinic, and the professional service would then be billed on a 1500, but both would be reimbursed according to the guidelines that we know for hospital outpatient areas.
Okay. Another question. What is coinsurance for off-campus clinic?
What is coinsurance for off-campus clinics? Medicare has come up with an alternative reimbursement methodology for off-campus, and we would need to bring up those amounts and look at each individual CPT code to understand what that coinsurance is going to be. It was stated that it would be 20% of the allowable payment, but as you know, CMS continues to change what coinsurance, how it's calculated, and what it is. And let me say this, I have up the final slide of the presentation. It has my email address. Anyone that wants to send me particular questions, or if you want to just have an individual telephone conversation, I will be glad to do that and find additional information for you and send it to you. So send me an email. I will find the amounts for you, and we can work on where you can locate those or where you can see exactly the amounts. But it's going to be individually different now based on the Medicare physician fee schedule.
Okay, another question. Is it possible to carve out any specific services or codes and then bill those as freestanding while still billing others as PB?
Not to Medicare. everything must be billed as PB to Medicare. But yes, if you look at specific services for your private or commercial payers, you can bill those just about any way you choose to bill. Now, I have to go back to the CMS or the Medicare requirement that we've had for years and years that every patient must be treated the same. Lately, that has been interpreted more that patients do not have to be billed the same, but they must receive the same services. So while I think the answer is for Medicare, no. If you are providing services in a recognized on-campus provider-based service area, then all Medicare patients must be billed as provider-based. How you charge and bill your commercial or private payers depends on your contract, as long as you don't, treat patients differently would be my answer.
Okay, then we can do one more. Does the EMTALA rules apply to on-campus provider-based RHC?
Yes.
Okay. Well, thank you again, Linda, for the great presentation today.
You are welcome. I am so sorry it was too long. And again,
no,
I will
I think
say,
everyone enjoyed it.
good. If you have questions, please just send them to my email. I will be glad to do my very best to help anyone that has questions. Thank you all. I enjoyed it.
Thank you so much. And at this time, I would like to thank everybody for joining us today. I hope you can all join us for our February webinar as well. And remember, as you exit today's webinar, you will be automatically routed to a survey. And we would love for your feedback and directions for future topics. So thank you again, Linda, for taking the time to prepare and share your knowledge and insight with our audience today. And I hope everyone has a great afternoon.
You are welcome. Thank you all for joining.
Thank you.
Bye.